sort of jump into it. So thank you, Jackie, for taking time to do this. I think it will be extremely beneficial for the CIRS community and also other members that are part of the CIRSLab space. And so yeah, thanks for joining. And maybe I'll do a really quick introduction for people who are listening now. And of course, this is going to be sort of recorded and later added into the real section of the CIRSLab space. But so just to do a quick intro, Dr. Jacki Meinhardt, for those of you who don't know, she is a board certified nurse practitioner, currently working at the Amen Clinic in Northern Virginia. And she's also teaching at Georgetown. You're in the biostatistics department teaching, is that right?
Yeah, I do. I teach biostatistics and epidemiology.
Got it.
In the graduate level program.
In the graduate level program. Oh, I'd love to. If I was still a grad student, I would love to join that class.
It's actually a lot of fun. I actually really enjoy it.
I can totally imagine. It kind of brings vibes of the graduate school days. But right, and so in addition to all of that, which is already pretty cool, you are one of the certified shoemaker practitioners. So you have a very deep understanding of CIRS as a chronic illness, not only from the practical point of view, but also on the research front, because you're one of the few practitioners who's been heavily involved in the research front, looking at all kinds of things tied to brain injury and genomics or gene expression, patterns of gene expression tied to CIRS and other overlapping aspects of illness that maybe we'll talk about a little bit. And she, in fact, is one of the co-authors in the very first paper that came out looking at actinomycetes, which is now the big thing on the radar in CIRS. And so looking at patterns of gene expression that could be tied to actinomycetes as it's related to exposure to water damaged buildings. And that's a very important paper. And I'm hoping more research can come out of that on that front, because it's really revolutionized sort of the scope of what CIRS means, you know, in terms of what kinds of things are contributing factors and how profound are these things in terms of contributing to the illness. So anyways, that's just a really nuts and bolts introduction for people who are joining. And of course, if we have, maybe, I don't know, maybe you're better than I am at this. If there's people asking questions in the chat, we can address them maybe towards the end. But I figured we could start out by talking about a couple of different topics that I think would be interesting to think about, obviously from the perspective of CIRS, but also, you know, some of these things that you've looked at as a practitioner, they can be conceived as being separate things that happen to overlap with CIRS. And one of those things that I thought, you know, when I looked at your website, you had a statement that was really interesting regarding mental health, where you say something like you've identified a range of pathologies on the mental health front that include things like anxiety, depression, and PTSD, and stress-related issues that are ultimately caused or rooted in chronic infections throughout the body. I thought that was a really interesting statement, and I was wondering if you could talk a little bit about the role of chronic infections, what role do they play in mental health, and what kinds of chronic infections do you typically see tied to these mental illnesses? And so how are the two causally related? And maybe we can bring that into the picture of CIRS, because there's going to be an overlap between these things, and maybe how to think about these things, if they're the same thing, if they're just separate things that just come together and then they create the profile of mental illness.
Yeah. And, you know, I have been really blessed in my career as a nurse back in the 1990s, training at Johns Hopkins in Baltimore, you know, it's like baptism by fire, right? You're kind of just thrown into it sometimes. And I really learned a lot about, you know, in the medical ICUs at Johns Hopkins about acute illness,
Yeah.
right? Like, and you get very good at acute illness
Hmm.
and signs to look out for, right? And then emergency medicine at Johns Hopkins, again, baptism by fire. I got really good at acute, looking at, you know, cardiovascular, respiratory, gut, overdose, you know, different types of illnesses that span the spectrum, right?
Yeah.
All body systems. Um, and then when I transitioned into a nurse practitioner in the early 2000s, and then went into kind of this family medicine, you know, so I see anyone basically about a year. I don't really like to go below a year, but year all the way to the end of the life cycle. So I see this grand span of patients, and I've had the honor of taking care of lots of patients in acute settings, but also in that chronic health settings, and then just a healthy setting, right? Just someone living their life. So I've really been blessed. And one of the things that you kind of touched on just a few moments ago was the research, right?
Hmm.
It's, and when you have the blessing to be able to interact with patients, whether they be healthy or they be in a challenging situation, I always look at it as like, wow, I'm really lucky I get to interact with this person, right? Because I want to get them better, right? Like how that empathy that has to be there, right? You want
Yeah.
to be there to help them. But
Right.
it's really great in the sense that I start to see trends. You start to hear the same thing sometimes over and over again, and you're like, why is this not happening? Why is this not getting better? So when we started talking, when I moved out this way to Northern Virginia, and I started working with this brilliant physician, and he taught me everything about CIRS, right? And he said to me, you know, hold on, you're going to learn something, and once you see it, you're never going to forget it. And I remember saying,
Who is
okay.
this physician, if you don't mind?
Dr. Andy Heyman, Dr.
Andrew
Andy.
Heyman, yes, and I'm sure a lot of people are here are familiar with, and I just want to say very quickly, interjection, that Andrew, his lectures was how I really got into CIRS. You know, I had already read some of the Shoemaker stuff, but it didn't click in the scope of understanding until I started seeing his lectures.
Yeah.
And I thought that was amazing. And I forgot to mention that you, right, were working with Andy Heyman initially. So you're coming from that group initially. And I'm glad that you're going to say something about that. So I'll let you keep
Yeah.
going.
It was not just learning about it and like literally learning and taking care of the patients and being like eyes wide open. Um, I was amazed, right? And then being able to communicate. So one of the big things that I like to do with patients, I can't speak for anyone else, but that I like to do is if you don't understand why I'm doing something, you're likely not going to do it the way I want you to do it. So it's really about educating the patient. Why,
Right.
like, what does this lab mean? Why does your house now bother you? Where you've lived there your whole life and you've never had a problem, why now? What is going on in your immune system? What does this lab value mean? Why am I making you take this VCS test, the visual contrast test, you know, every time before you see me? Like, why do I ask you to do that? Why do I care about your ADH and osmolarity? If you pee too much for what you drink, like those are all the questions. And people kind of look at me side eye and I'm like, this is why I'm asking. And then they're like, oh, let me tell you. And then they get excited to share with me, you know, their symptoms and how they're either getting better or worse or whatever it is that they're doing. But it's really that education that I think is really paramount, is educating the patient from day one, right? And then once I started working, you know, in that field, people come to you and there's things that aren't related to mold or actinomycetes, right? So like not everything is related to that. So you have to, again, eyes wide open. We started seeing different types of infections. We started
Mm-hmm.
seeing, this is before we even knew what EDS was, Ehlers-Danlos, before we knew it as hypermobility syndrome, right? Like, and we started saying like, wow, like, wait a minute, whoa, you know? And then it was, you know, these histamine intolerance patients and mast cell, and then all of a sudden these words, this is back in like 2013-ish, right? When we're
Wow.
starting to see some of these things and we're asking the questions, you know, what's going on here? So we're really we really kind of started to understand more about the immune system, more about how an indoor environment can affect individuals, right? And then when we started looking at infections, right? I live right in the middle of Lyme Central, right? There's just ticks everywhere. So I got a crash course in Lyme disease, back in 2010, 2012, that time frame. And that's kind of like, wait a minute, wow, like this is really amazing in a scary way. This is really an amazing illness. Now, I got to say, my mom had Lyme disease in 1980s, maybe.
Yeah.
And I remember she had a terrible time treating it. We were in New Jersey at the time, but no one knew anything about it, right?
Yeah.
So that's why I really, again, I take the stance that I'm so grateful that I get to do what I do and then see those trends, see how treatment evolves into helping people get better, because no one patient is the same. Everyone needs to be different, treated like their individual self within the paradigm of CIRS protocol, right? Because no one person wrote the book on CIRS, right? To be true. So when we start talking about infections, and I think COVID is a great example because it's fresh on the mind and everyone heard about it.
Glad you brought that up.
Every day we heard about it for 2 years, right? Almost to the point that you didn't want to turn the TV on because it was so scary. But COVID is acute inflammatory response syndrome. Remember that first cases that December when everyone was getting really sick in the hospital and being admitted? That was the acute inflammatory response, right? That cytokine storm that would happen. And that's the difference. That was acute hospital ICU versus chronic, something that we see over a long period of time with our patient population in CIRS. Because they say, I had a patient yesterday who was discharged, but I see her once a year, right? She came just to see me for her annual CIRS healed. And she said to me, I forget how to explain what happened to me. And I said, well, think about COVID. That's acute. What happened to you is long-term, over a long period of time, your body changed. And it's really fascinating. So when we start talking about infections, like my question always was, why is this person treated and getting better? And why is this person having a really tough time with treatment and not getting better? In fact, everything we're doing with this patient is not working, right? Like what's going on? Is it their home? Is it their work, school, whatever their environment is? Let's say everything's perfect, pristine. And then all of a sudden, it's not that, right? It's kind of like, like you have to start asking those questions. Because I say to patients, I want you to hold me accountable, right? If I'm not getting you feel better within a certain period of time, we have to have a discussion. What are we missing, right? Because again, not everything is, a lot is, but not everything is related to, mold and actino. But it's just fascinating to me. So bugs. So when we start talking about bacteria and viruses, that innate immune, so you and I have one immune system. In that one immune system, we have two pathways, the innate and the adaptive.
Right.
Simply speaking, the innate immune system tells the adaptive immune system what to do, right? So bacteria, virus, parasite, dander, pollen, mold, whatever comes into, actino comes into your body, the innate immune system, simply speaking, stands up and says, wait a minute, you don't belong here, and tags it. That tag alerts the body, right, for this other side of the immune system to get to work, right, to do what it needs to do. That tag that happens, that antigen presentation, if you will, that happens, it also alerts the liver and kidneys downstream to get rid of whatever that toxin is, right? So you and I have one circulatory system, right? Blood, head to toe, and all the organs in between. We have a second circulatory system called the hepatic portal circulation, and it runs east to west, simply speaking, right? It just kind of runs in a circle sideways here with our liver, our pancreas, our gallbladder, and it basically detoxifies. It's a big fancy word for the body, but the liver and kidneys look for that tag to get rid of it, to get rid of the crap, no pun intended, in your system. If your body loses the ability to tag the good from the bad, the liver and kidneys don't know how to get rid of it. And that's why binders are so important when we start talking about it. And people say with or without food. And I'm like, you really need to eat something because you have to activate that hepatic portal circulation. If you take your binder at nighttime, it's not really going to do a whole lot, right? Because your bile should not be working at nighttime if you're fasting or in an unfed state, right?
Yeah.
So, so we start to see that immune system dysfunction. Simply put, that's what CIRS is. It's that immune system dysfunction that's happening.
And just to clarify something, so in the context of immune, right, this immune response, the body has a hard time potentially differentiating a living organism threat from the biotoxin, which is an inert particle, right? And that's part of the problem in this illness, that you're getting this double whammy immune activity. And it's essentially overwhelming the system, particularly as you say the liver, right? So that distinction is true, right?
Yes, it absolutely is. But again, like the body still loses that ability to tag the good from the bad, right?
Yeah.
And yes, that is, someone just asked the question in the chat room, that's that HLA, that human leukocyte antigen blood test that we do at LabCorp. If you have the HLA, it just means that you're in that 25%, 25% of the population that genetically has this issue, right? So this person yesterday, for example, said to me, why now? Why am I just getting sick now? I've lived in this house my whole life. And we looked back and I said, well, there's usually a trigger, a physical, emotional, traumatic experience, or surgical experience, a bad infection. I don't know, right? That's where we start to have that deeper conversation. And we may, and I always say to patients, and this, some people really don't like it, but we may never figure out what your trigger was. We may never figure it out. But the goal of treatment, I always say, is to get rid of your symptoms slowly, right? So that when you have that tell, some people know they get into a moldy environment or an environment high in actino and they start to sneeze, right? Or they start to have a runny nose or their eyes itches or they get a headache, right? They'll be like, oh my God, my head. What I say, that's your tell. That means you need to get out of that environment, right?
Yeah.
Assuming you're not dehydrated or anything else, getting a really bad headache, you know, nothing else is going on. But that to me is a sign to get out of Dodge, right? Get your body moving. And then when we start talking about when your body loses the ability, so let's say that there's a bacteria, virus, parasite in your system. Right now, bacteria and viruses and parasites, they've been around a lot longer than you and I have. They're really brilliant. So they can evade the immune system, right? I always like to say, they will evade the immune system. So it goes deeper than the HLA in some patients when it comes to that embedded infection. But my current research, which I'm really excited about, I'm not ready to talk about it yet as far as the findings are yet, but it's looking at why some people get treated with bacteria, with antibiotics for bacteria or viruses and parasites, why some get better and why some don't. It all comes down to, and we talk about it in CIRS, factor 5, plasminogen activation inhibitor. It comes down to basically fibrin. Right. And we learned that with COVID, right, with COVID-19. So if you get a cut on your arm or your leg or wherever, you're going to get platelets and fibrin accumulation, right? And it's going to come and clot your blood and help you heal. Normal. Some people have a defense. So the defense mechanism is the fibrin, right? Bacteria and viruses in our body, their defense mechanism is biofilm. They make biofilm. They call it the bug's poop. You know, they make it and then they live in it. They like to. It's their safe spot. Our probiotics, our good bugs in our belly, have biofilm. So there's kind of good biofilm and bad biofilm, right, if you will. But if you look at E. coli, if you look at actinomycetes, which I see in people's bladder, I see in people's sinuses, I see in people's prostate, in their gut, right? I see it everywhere, which is actually kind of Dr. Doring, Colorado. He and I are having a lot of conversations about that because I test, right? I have patients with these symptoms and I test and I figure it out. People with IC, bladder infections, embedded urinary tract infections.
Can you briefly just say, sorry to interrupt, how can people get tested for that if they suspect they have something in the bladder? Because, you know, I mean, I don't know if the microbiology DX testing for Marcons would pick up on the actinos.
Yeah, they do. I've seen actino in the microbiology DX does test for actino. So if it's there, you'll find it. You can test in the urine. You can test your semen, prostate. You can test vaginally. I've seen actino in the vagina. Typically, Microgen DX is the company that does the body serums, right? You can
Microgen DX. Okay.
MICROGEN DX. Yep.
Okay.
They do lots of different body testing, right? Next generation sequencing, right?
Mm.
For urine, I use Microgen, or I use CIRS, or I use Pathnostics. CIRS and Pathnostics are 100% covered by insurance, which is really nice. I shouldn't say that. They're not, they may not be 100% for everybody, but they're the ones that have the best coverage. And I do like to use insurance, right? I do like to use insurance. You guys pay for insurance, like you pay good money for that. You might as well use it, right?
Right. Right.
Because this
Yes.
illness is very expensive. So I always try to use insurance whenever possible. So CIRS and Pathnostics do urine. They also do semen. Microgen does semen, urine, vagina, sinus, lung, and then wounds. They do a bunch of wounds. And you can find actino there. So what do you do when you find actino? You treat it, right? So you can treat it. Now, actinomycetes is a bacteria that is naturally found outside, right? It's naturally in the dirt. Meaning if you wear your shoes inside, if you roll around in the dirt, and you come inside and you don't take off your clothes, you're going to sit down on your couch with actino in it. I like to say to people, actinomycetes in the house looks like dust bunnies, right? It kind of looks like that dust that forms, or dirt, right? You'll see the dirt there too. So there's no way of getting rid of actinos like mold, like you cut it out and you remove it from your home physically. Actino is just literally, you have to clean and be mindful of what you're bringing in the house. So I say to people with cats and dogs and kids, like, I don't know how to help you here, right? Because they just come in, right? But you got to wash them off or clean off their feet or whatever, right? And the kids, the same thing, right? Because they're playing, right? You want them to have fun outside.
Yeah.
But how do you prevent the outside from getting inside? So yeah, so when we start talking about these bacteria, the biofilm protects the bug, right? But our body has a defense mechanism against the biofilm, and it's called fibrin, and it creates this fibrous cap over the bug and the biofilm. So you almost need a double whammy to get through the fibrous cap to get to the biofilm to get to the bug. And that's with Lyme, Babesia, Bartonella, Ehrlichia, Rocky Mount, any of the bugs. Sinus, Marcons, same thing. I like to think of Marcons. I tell people, think of a brick wall, right? Your sinus is a brick wall, and the brick is the bug, right? The mortar is the biofilm, and we're slowly going through, because people will be like, Jackie, I have this multiple antibiotic resistant coag-negative staph in my nose, and it takes multiple months to get rid of it, right? And then you go to CVS and someone sneezes on you and you get it again, right? So it's not like a one and done, like you can get it multiple times. But think of it as this brick wall, right? You've got to get through the fibrin to get to the biofilm to get to the bug. Yeah.
Okay. And you mentioned fibrin. So is there a connection here with some of the bleeding abnormalities that have become very prominent in CIRS?
I think so. I can't necessarily say yes yet.
Okay.
That's one thing I'm not prepared to talk about it, but I just got the slide deck. So even though I teach biostatistics, I just got the slide deck from my statistician who who went through it at Amen Clinic, because we're also looking at brains, right? So I look at a lot of brains, whether it be neuroresponse or SPECT scans.
We'll talk about that in a moment too. Yes.
I love brains, and
yes.
Yeah, so I'm not prepared to talk about it yet, but I do think that there is something there. I'll be probably talking about that by February next year.
Okay.
Through it. Yeah.
Okay.
Yeah, but it's because if you think about transgrowth factor, I get so excited.
I can see it in your face. Yes, I like this.
Because transgrowth factor beta 1, and this is how it happened. This is like the light bulb moment, if you will. Like TGF beta 1, I've been working with this lab value for years, right? With Dr. Shoemaker, with Dr. Heyman, with all the other doctors that we work with that are, partners. And transgrowth factor beta 1 is in the same pathway as some of the clotting factor, the same genetic pathway as some of the clotting factors. And when I started talking with this brilliant nurse practitioner, her name is Ruth Chris, who treated urinary tract infections. She retired and she transferred a lot of patients over to me because we understood it, right? And she taught me about plasminogen activation inhibitor in the sense of urinary tract infections. But I started seeing this pattern and I was like, wait a minute, this is the same thing as CIRS, right? So I started getting those patients kind of talking about it, but it was actinomycetes. It wasn't necessarily mold, because I started seeing it in their urine and their prostates. And I was like, holy moly, like what's going on here? And then we would do like the clotting cascade, right? LabCorp, and their
Yeah.
cat complexes would be elevated, right? And their A2, it wouldn't be working the same way, right? It wasn't working correctly. And I was like, oh my God, this is CIRS, right? And that's what led me to the conversation. That's what led me to the hypothesis that led me to those research aims. And, you know, as a researcher too, right? Like all of a sudden you start following this thread, right? And it's,
Yeah.
you know, it's kind of like, oh my God, how is this going to help my patients? Like, this is so cool. So once I started merging those two conversations together of the embedded infections and the chronic inflammatory response, and I started treating them similarly, not everybody needed it, but a lot of them did, started getting better, right? And then
Wow.
I started saying, wow, like, holy moly, let me do this with my Marcon's patients. Like, let me think of how am I changing the way I treat my Marcon's patients, right?
Yeah. And
Yeah.
there's a lot of ongoing debate right now on what's the best way to deal with Marcons and how to even think about eradication of Marcons, if that's even plausible or if that should be the goal. And I don't know what your experience has been in that front.
So a lot of really smart people have talked about this, right? Dr. Shoemaker, Dr. Neil Nathan, like really smart people, right? Who understand. I happen to think Marcons is a big deal. I think it is a big deal. I don't think that it should be kind of swept under the rug and just avoided. I do think it needs to be treated. That being said, you could work for 6 months trying to eradicate it. And like I said, go to the supermarket and get coughed on or sneezed on, right? It's still an infection that you can get that just happens to be resistant to many different antibiotics.
Yeah.
It's just, you know what I mean? So I say to people, you know, wash your hands, cover your mouth when you're coughing and sneezing, get away from sick people, you know, because it's not a one and done.
Yeah.
Right. And that's the unfortunate part. And people get really frustrated, rightfully so. But let's not forget, Marcons is because melanocyte stimulating hormone is low. So everything I'm doing is trying to increase that melanocyte stimulating hormone. And I think that gets lost in the conversation,
Yeah.
right? Like we kind of don't even talk about MSH, but we really should. We really should talk about it more.
I'm planning on giving a workshop on MSH because it's so overlooked at many patients and I think even among some practitioners who may have some grasp of CIRS. But right, and I don't know. I mean, the traditional way to do that, right, is to obviously follow these steps, removing yourself from exposure, the binders, and then trying to eradicate Marcons, and then presumably VIP would be the thing that would start giving you a leverage in the race of bringing MSH up, right, until Marcons is eventually contained.
I think you can also consider that ACTH cortisol combination, right? I think and again, I think this is where that conversation happens. Everyone's talking about morning cortisol. And I say, well, okay, well, what's the ACTH look like? What does that look like? Can we do both of those at the same time? Because if the ACTH is low and the cortisol is high, you've got, I mean, I don't know what the analogy is, but that's a lot of hard work, right? That's going to be taking time to get the ACTH higher and the cortisol lower, a little bit lower than that. Because in theory, you want your ACTH to be roughly 3 to 4 times that of cortisol. So if your cortisol is like a 12, just for math purposes, easy math, even though I love statistics, I don't like math. So let's just say it's a 10, for math purposes, you want your ACTH to be 40, right? Roughly, right? You want it to be a little bit higher because that also helps with deep sleep. Right. So I think we kind of lose the conversation about Marcons, but we don't necessarily talk about how infections impact that stress response and how CIRS affects this, because ultimately it's that immune dysfunction paired with the adrenal dysfunction as well.
Yeah. So you're saying that in order to get rid of Marcons, if you have a chronic infection situation, that treating that infection is going to be really important to successfully also deal with Marcons afterwards? Is that? Yes.
So I think that when we start talking about MARCONs, we want to treat MARCONs to allow the MSH to come up. So it's almost like a weighted balance where you're
Exactly.
trying to suppress the trying to suppress the MARCON so the immune system can do what it does. Because don't forget, melanocyte, the melanocyte stimulating hormone not only impacts, it's the master hormone in the entire body, right? So it's like the mother of all hormones, if you will, but it also impacts the adrenals. It starts talking about, we start talking about that stress response. So if that's not working, you're going to constantly be like this. We want to be more like this. Now, melanocyte stimulating hormone, I check it once in the beginning, and then I check it maybe once a year. It doesn't change that fast, right? So just,
Oh, really?
and
Interesting.
in my experience, it doesn't change that fast. So I don't like to, I don't want to say waste money, but that's not covered by insurance, right? So
Yeah.
I typically only do it maybe every 6 months, maybe once a year.
Got it.
Yeah.
Got it. Going back to so you mentioned the actinos, and I just want to go back to that because one thing that popped up to my mind when you said that was we put a lot of emphasis on things like Candida and like yeast overgrowth, and I'm wondering how many cases of people with underlying actino overgrowth or other infections are really suffering from these other things and not from Candida. And it's just like, and so I don't know how often, if it's something that's easy to tease apart, and how often do you think this is like misleadingly attributed to something like a yeast or fungal overgrowth? And some people even talk about mold colonization and that kind of stuff, and they think they have like some kind of mold infection.
Yeah.
Yeah.
Number one, I typically don't treat Candida. I do treat Candida, but I typically don't treat Candida unless there's a positive test, right? So like I do look at the blood and I do look at stool and I do look at urine. If there's yeast, trust me, I'm all over it. If certain markers are elevated, I will treat yeast because I also think parasites, right? When it comes to yeast, especially in the gut or the bladder, I see parasites in the bladder a lot. But they'll hide in the yeast, right? So if I do see Candida yeast, I do go after it pretty hard,
Okay.
but I just don't start people off on itraconazole, right? I don't do that. I
Okay.
have itraconazole. There's a huge amount of resistance to those medications. And again, working in the ICUs for years, like when you don't have anything to treat the sickest of the sick patient in the ICUs, you learn to save those for, not to say that they do work. I want them to work. And I think some people definitely have improvement with them, but it's not something that I just automatically put people on. No.
I see.
Yeah.
That's a good, and then there's also, the concern about if you're in the hypometabolic state, potentially, depending on where your brain is at, whether some of these antifungals could contribute to the progression of that. And
Absolutely.
I don't know if it's something, I would suppose someone who's well-versed in Genie and the neuroquant that you would think of that as something to keep in mind if you're doing the antifungals.
It decreases the electron transport chain, right? It affects how energy moves in the cell, right? So it actually suppresses that. So I don't use it again, unless there's a positive test. I do reserve those medications because there's a time and a place for everything, I like to say.
Yeah.
If there's I don't want to overuse something that may cause harm, long term, right?
Right. The other thing is that MSH, theoretically, erasing MSH would also help keep these things in check, right? Like Candida, overgrowths, and other things. I mean, not
In
just
theory.
Marcons, in theory.
Yeah, in theory.
So,
But MSH does take time to increase. It's not something that happens overnight,
yeah.
unfortunately.
And how do you mentioned ACTH.
Mm-hmm.
So how do you, if you don't mind sharing a little bit about would you go about treating ACTH if you think it's too low?
Yeah, so I focus, usually those patients, they'll actually tell me they don't sleep well. So I kind of already know that they're probably not getting good deep sleep. When we start talking about sleep, don't forget, sleep has a cycle. So it's deep typically in the beginning, light sleep, and then REM sleep, but they're kind of mixed in a little bit, but it's usually deep and then REM, assuming you go to bed in the nighttime and wake up in the morning, right? I know that when they have the ACTH in their cortisol isn't appropriate or functioning appropriately, they're probably going to be losing a lot of that deep sleep and they go to bed late in the morning. right? At 3 a.m., 4 a.m. Some people go to bed at 7 a.m. because they're awake all night and they can't get to
Yeah.
sleep. That has to do, there's a lot of sleep training there, kind of what we talked about, right? There's a lot of sleep training, how you have to slowly decrease or slowly move back your bedtime. But then things like different adaptogens, we'll work on those pretty strong. I'm not a fan of melatonin, like high dose melatonin, unless it's COVID, then I do a lot of melatonin, but it's not typically for me personally, like I'm sure it's great for other people. There's a lot of conflicting evidence about what the appropriate dose is for melatonin in just the average patient. And we know that while a little bit is good, how much is a little bit? Like, is a little bit 10 milligrams, is a little bit 20 milligrams? The research suggests with COVID, 20 milligrams is ideal, right? We want to give them a lot. Should we be giving CIRS patients that much? I don't know. I don't have data on that to suggest that's appropriate. But typically I go after magnesium, again, because patients are usually constipated too. So getting magnesium in there somewhere. And then also doing things like apigenin, which is chamomile. So you can't drink as much chamomile tea as what's in apigenin, which is great. And then theanine, L-theanine, which is green tea, decaf green tea. So I typically say do those three, and then we'll do cortisol manager, which is ashwagandha, and a little bit of melatonin. We'll do a lot of theanine, GABA-calm, different GABA products. That typically helps. And then I try to use whatever the patient has. So I'll use, if they have supplements at home, like adaptogens at home, I'll try to use those first. But we'll time them appropriately, right? So that it's all about the timing.
Yeah, I was gonna say that. So in the shoemaker protocol, where would you time those? Would it be from the get-go, or would it be after a certain step?
Oh, no,
I
I
would.
do it from the beginning. Yeah, people need their sleep. Like if you're not getting a good amount of deep sleep, you probably won't heal as well as you could, right? So I'm always looking at sleep.
Okay.
Every visit, we're talking about sleep and how we can make it better, right? But sleep is a challenge for a lot of patients, right? So I don't want people to get discouraged, right? It is a work in progress for most everybody, kids or adults. So
Okay.
yeah, and it's all the things too, right? It's red light therapy. It's if you have a sauna therapy, right? It's relaxation. It's getting off your TV. It's getting off your phone. It's meditation, right? Typically, I don't like meditation at nighttime, too close to bedtime, but it's deep breathing, right? It's all the things that we tell you to do too with those supplements. And then I do use drugs, right? I do use medications that will put people to sleep if I need to, but I try to do supplements first.
Okay.
Yeah.
Okay, that's very helpful to know.
Yeah.
So I guess, okay, so maybe we'll do a little bit of a transition here and segue into a little bit of the brain for the remainder of the time.
Yeah.
And yeah, I mean, right, I'm sure we can spend like multiple lives talking about different aspects here. And maybe this is a point of intersection between you and I in terms of research. And obviously you have a lot of experience in terms of thinking in clinical settings about how the brain is affected. And maybe we can start by talking a little bit about, okay, so you've talked about the infections. You have all these potential infections. And what do you see in the brain happening as a result of chronic infections? Are there specific patterns of brain abnormalities that you can tie to a person with infections? Both, I mean, I guess in the context of CIRS, and I don't know, maybe we can start there and take it from there.
Yeah. So my doctoral work at Georgetown was looking at 30-year-olds to 50-year-olds, men and women, with subjective cognitive impairment. So they noticed the issue. No one else noticed, but they said, oh, why am I forgetting my keys? Why am I going in this room? They started asking questions, right? And I based it all off the CIRS questionnaire, that visual contrast questionnaire. I picked a couple questions from there.
I see.
And because I used the VCS as one of my criteria. And we looked at that. We looked at blood values, and we looked at something called neuronal injury, right? So neuronal injury is basically any injury that happens to the brain. An acquired neuronal injury is something that happens that you didn't bump your head. It's usually from some sort of inflammatory event, right? That's not blunt force trauma, right? An acquired injury. And I looked at so these men and women with subjective cognitive impairment. And I noticed that when their TGF beta 1 was high, their VEGF and their MMP9 and their C4A were elevated, they had areas of the brain that were changed. And this is very similar to what Dr. Shoemaker saw when he did the neuroquant evaluation back in the early 2000s, his papers that looked at that. Well, I said, well, let's go ahead and look at this again, looking at the neuroquant, and then add the blood values to it. So when we saw when TGF beta 1 was high, which goes high for lots of different reasons, don't forget TGF beta is both pro-inflammatory and anti-inflammatory depending on the titer. TGF beta 1, the pleiotropic cytokine, which is a byproduct of the immune system, right? So it goes high with immune activation of some sort, right? So when TGF beta 1 went high, we saw changes in the limbic system, right? So the caudate and the putamen were actually smaller than other people who didn't have injury, right? Who had no injury, or not injury, but no neuronal injury. And then we saw areas of the brain that got larger. I can't say atrophy because that's technically a diagnostic term, but we saw like this hypertrophy diagnostic term. I'm not going to use that, but like it was more plump than other patients that were in their 40s and 50s. Because that's what the neuroquant does. The neuroquant looks at age matched controls. So for me, it would look at a 50-year-old woman with no symptoms, right? That's what it would compare it to. And the neuroquant is a phenomenal test. Again, you can't diagnose off the neuroquant though. So you have to be very careful about the way you, you talk about it with patients. Because I do like to be very upfront about that. But you do see changes in different areas of the brain, the shape, the size, and the volume, right, of those different areas, specifically in the limbic system. So I would see those changes. And we know, based off Dr. Shoemaker's work, that VIP helps plump those areas back up that are small and helps decrease those sizes that are large, right, over time.
Right.
And that's been published multiple times, not just Dr. Shoemaker, but with other patients as well. And then there's also a couple companies. I think you and I spoke about this actually, Christian, about the company in Philadelphia that was looking at VIP intravenously, who was doing the work with COVID, right? They actually saw great work with IV VIP under the research protocol. So
that's really interesting. And is it something that's currently widely available or not really?
No, so VIP is available as a nasal spray. It also now, they have a new formulation that's a tab that you put in your mouth. You don't swallow it, but I think you put it underneath your tongue. It's available in research protocol as a sub-injectable, a sub-Q injectable out of California. They're in stage 2 or 3, phase 2 or 3 research right now. And then there is in stage 4 research out of Philly. Phase Bio, I think it's called, the company. They're looking at VIP intravenously, but for COVID patients. So all of this is for COVID. But yeah, it was on clinical government. Clinicaltrials.gov. It was all over there. Pretty impressive. The people that were doing the Phase Bio. Back in long time ago, I used to work at Pfizer Pharmaceuticals, and they are people that I knew when I was at Pfizer. So I called them up and was like, tell me all about this. It's pretty fascinating.
So, I mean, I'm somewhat familiar with some of these studies for acute COVID. I know there were some studies looking at VIP intravenously as a potential, and I think that there were some potential, positive findings there, right?
Oh, there was a lot. Yeah, there was a bunch of findings.
And
it was not allowed for emergency use though. So it's not available to patients. It's only available as a research protocol still. And I don't know exactly why. They didn't tell me why, what happened, but the FDA came out and said no to the emergency.
Imagine
use.
Yeah. Well, hopefully that will change in the near future, and hopefully VIP is something that becomes more widely available and known, because it seems to have a lot of different applications. So one thing I wanted to ask, something that I've seen a lot in patients is having a history of concussion. So you talked about brain injury, or some kind of traumatic brain injury or neuronal injury due to some sort of internal inflammatory process. But have you seen a lot of patients who have like a history of concussion and also, eventually landing in something like CIRS because of that?
Yeah, absolutely. They'll actually be fine, and then they'll get a concussion, and they'll have an inflammatory response after the concussion.
Okay.
Absolutely, we see that. And then the more concussions they have, more blows to the head they have, oftentimes, and everyone's different. You know, I've seen one concussion cause it. I've seen the third concussion cause it, right? So it really does depend on the person.
Yeah.
I see a lot of people talking in the chat box about phospholipids, and they're probably one of my favorite things. It's foundational to my protocol, the phospholipids. You know, so I am a big fan of phosphatidylcholine. We give it IV, we give it orally, we give it rectally, and I think it's I love it, especially for those concussion patients and then all CIRS patients, especially when
Yeah.
we start talking about the brain, right? And that neuronal injury, one of the things that we do is get them on those healthy fats, right? The phosphatidylcholine, the phosphatidylendonolamine, the inositol, we'll get them on that again because it needs to build up that cellular membrane.
So then essentially someone who is CIRS susceptible could have a triggering event through something like episodes of concussion potentially.
Absolutely.
And so that can potentially set them up for becoming environmentally sick, right? So it's not just the concussion on its own. You kind of have to go through the same protocol basically.
Yeah, we at the Amen Clinic, we have a concussion protocol, right? And actually think of an actual protocol that we give patients. And a lot of it you'll see is CIRS supported, right? A lot of the things that we do is, but we do it in an immediate succession. We do it very quickly. We don't wait like a protocol. We kind of give it to everybody very fast because we don't want people to have long-term effects. If we can do something in the first 48 hours, again, whenever there is a concussion, the first 48 hours are always very important, you know, to get them immediate care. Even if it's, you know, we give them hormones, we give them lots of different things, right, to support
Wow.
their brain.
It would be amazing to, if, you know, someday we had data looking at, you know, whether this could potentially work as a preventive treatment protocol for triggering CIRS. Who is more likely to develop CIRS if you're able to like contain that inflammatory response early on? And then, I don't know, that's something we know, you know, from a research perspective would be fascinating
Yeah, so
to
there's
show.
a brilliant doctor at Amen Clinic who just does concussions, and that's all his research is off of concussions. We have a really great concussion center here in Northern Virginia that follows University of Pittsburgh, right? So the fellow that started it here went to Pittsburgh and got trained by the guy who did the CTE, right? The doctor who discovered CTE a couple of years ago. It's fascinating. It's a whole other side of medicine. I am not qualified to talk about it, but we do. I know the protocol, right? What to do for the first 48 hours, 72 hours to get them. Yeah. So
Which can save a lot of lives. It's fascinating.
especially these young kids playing all the sports, right?
Right,
Getting
and
concussions
I
in
know, I
sports.
remember when I saw this research coming out looking at soccer players. They
Yes.
were right. And I'm like, no, but you know, I'm a soccer fan of sports, but and yeah, it's one of those things that we're gonna have to eventually rethink some of these things as a society because it's quite
Yeah.
serious. Right, you're getting these very low grade episodes of chronic or subtle inflammation, micro-inflammatory events, and you know, I mean, so, I don't know if some people they might be better able to quell that, and then there's just people who really like are much more susceptible to developing other issues down the line.
Yeah.
So yeah, wow, that's really interesting. I guess so. So for those, you know, if you have the concussions, in principle, something like VIP would be very helpful treating those patients. Of course, there's probably other things that you would have to do. You mentioned the phosphatidylcholine. I know are you a fan of synapsin still? Because I know Andy used to be at least.
Yeah, I think synapsin's great. Some people can't tolerate the high B12 though. So I think it's a great product. Some people just can't. It's kind of I almost start them off on high B12 before I give them because it's an expensive product to not be able to tolerate, right? So
Yeah.
I'd like to see if they can tolerate it before I give them a prescription. I like the synapsin. They have a nasal spray. They have an under the tongue. I think they're both great. And it's helped a lot of people, right? It has helped a lot of people. Some people, like I said, can't tolerate the high B12, so we have to we take that out, right?
Yeah. I had mixed feelings with it actually, and I think for me maybe it was because of I suspected I was having a lot of bleeding abnormalities, and I don't know to what extent the RG3 component that it was having a blood thinning effect, and it was actually making a lot of the bleeding things worse. So I had to stop it,
Yeah.
unfortunately.
Yeah.
I don't know if that's, yeah, that was my experience. Otherwise, I remember getting a lot of cognitive boost when I tried it. It was like, whoa, I'm very alert
Yeah.
suddenly.
Oh, I'm glad you had that.
Like,
I'm glad it worked a little bit for you. I'm sorry that you
yeah.
had some other issues. But
Yeah.
again, like I said, everyone's different. So no one patient, right, wrote the book, if you will. Everyone's going to be a little different. And so, like I said, it's an expensive product to
Yeah.
prescribe and then patient not tolerate, right? So,
Yeah.
yeah.
Someone's asking, maybe we'll take a few questions
Yeah,
before
absolutely.
people, why can't we tolerate high B12?
So
So you just
typically
mentioned that.
genetically, right? It usually has to do with genetics. It's more than just methylation with MTHFR. We think about PEMT, COMT, different types of genetic mutations along that same vein, if you will, associated with MTHFR, right? There's a couple other things out there which we look at also.
Okay, so that, I mean, you're right. So people talk a lot about MTHFR, and so that, in your opinion, plays a role, right? It's something that you should look at in CIRS.
I love genetics, right? So I love genetics. I love genomics. I love both of it. I think genetics are a big help when we start looking at generalized foundational medicine, right? So if you have MTHFR, there's a few variants that you could potentially have, and we treat them slightly different, right? But it's not just about MTHFR. It's also about the COMT, which is right next to the MTHFR when you start looking at the cycle, right? If you have, and everything works with each other. So if you have a PEMT mutation, you absolutely need phosphatidylcholine, right? Like there's no doubt about it. You are probably going to be estrogen dominant, man or woman, right? You're going to have more estrogen than you need, and you're not going to be able to break down the estrogen. Phosphatidylcholine helps with that, right? So, and like, so a lot of people don't know that, and that's kind of a hot button for me because I'm always pushing for, especially women's health, right? Think a
Yes.
lot of women who have chronic inflammatory illnesses like CIRS also have other women's health issues, whether it be breast changes, endometriosis. Those are all high estrogen states, right? So if you have PEMT, it doesn't matter. You can add CIRS on top of that. We need to get you on phosphatidylcholine regardless, right?
Yeah, I'm
Right.
a
So
huge fan of
yeah,
PC. Yeah, I take it religiously, and as I gotten better, I started noticing, oh wow, this is like doing something at a very general level. Like I used to be an extremely hyper-reactive person. I still react, but when I take it, sometimes like these reactivities just go
yeah,
away momentarily. It's quite powerful stuff. So,
yeah,
um,
yeah. So so and then you so PEMT and then COMT on top of that, and then the urea cycle. Like there's so many. So when we talk about it, and so it's not like I'm saying, you know, don't do MTHFR. It's just it's so much bigger than MTHFR, and it's important that we learn about all of those genes because they all interact with each other, right?
mhm.
Especially when it comes to energy expenditures.
Yeah, yeah. Okay, that's helpful to know. So I'll take one more question here. And so, what if a person has an intermediate low MSH haplotype? Yeah, not a lot of people get to talk about this haplotype that's low MSH. Basically, the question is, my understanding is that they will struggle with anabolic regulation constantly. So, how do you suggest bringing up MSH for these patients, if it's
Yeah,
even possible?
yeah, right. And there's been no clinical research on it, so I can't say this is how you do it, right? Specifically, right? When it comes to low MSH in those clients, it's usually all the things, right? So it's helping with the stress response, it's helping with all the things that we talked about, right? So things like infrared sauna, um, hot saunas, whatever you have your access to. I think more research is done on hot sauna than the infrared sauna, published research, right? So usually cold therapy, right? Those types of things help raise MSH. In theory, in all patients, not CIRS patients, right? But in all patients, the research been done. There's been no research on CIRS and raising MSH in that sense, right? Like what's doing it. But we can look at what raises MSH in the general population.
In the general population.
Exactly. So, and then try to extrapolate it. I wish I could answer that question more, but I don't want to point in the direction of something and it not help you, right? Again, the research isn't there.
Right. I know a lot of people have talked about sunlight exposure as being one, right? That, and I know a few people that have been doing a lot of tanning to get the to try to get the MSH up in some form.
I do. I'm not a fan of all the peptides. Like, so I do VIP, but then there's like melanotan and some of the other the injectable peptides. I have a lot of caution. I have a lot of respect for those peptides, but there's a lot that I can't answer, right, when it comes to those peptides. So I always say do your research before you start them, because some people come to me on them, or they'll be on melanotan, ipamorelin, CJC. They'll be on all these different peptides, and I'm like, ooh, like what do we do? You know, because there's not enough research on them all together at the same time, right? Raising MSH or raising the different energy expenditures, the different energy markers. So I'm always very cautious there, right? But there's a question here that talks about VIP before the 12th step. I use VIP almost simultaneously. When someone has a Marcons, if they're Marcons positive, I get them on treatment for Marcons, whatever that is, depending on their test result. And then I get them on VIP, usually within 2 months after getting them started on Marcons treatment. I actually started, and that's something that, a bunch of the CIRS doctors also do, right? We kind of get them, or I should say the shoemaker trained doctors we do, we get them on pretty quickly, because we know that VIP helps with neuronal injury, and we don't want to delay any of the impact, right? We want to get that patient better faster. We don't want their brain to change more.
So that's regardless of whether they test positive or negative in the Marcons, so 2 months after treatment?
Yeah, if they're on Marcons treatment, I just say that you have to be on Marcons treatment, like standard treatment like we normally do, but then we're going to get you on VIP, right? Usually within 2 months, assuming they tolerate it. And then we'll test about every 3 months of treatment. That's what I do. I test every 3 months for Marcons.
And you found EDTA to be sufficient to do for this, or are you doing anything else for them?
So this goes back to that whole fibrin conversation, right? So I'm actually doing, depending on the patient, if they have PI1, if they have TAC complexes, if they have these other things that are elevated, I'll actually start either a lumbrokinase, Bluc.
I used to take those. We're really amazing when I first started them.
Yeah. So be careful though, right? Because you said that you have some bleeding issues.
Yeah, they came afterwards, later down the line when I started. I started doing these biofilm busters or lumbrokinase before I even knew about CIRS. It was at the very beginning, and it helped a lot. I didn't know exactly why, but that might have been one reason. Eventually, once I started doing the shoemaker protocol, that's when I started developing more of these coagulation issues and microbleeds.
Interesting. So
I was living in a water jam. Yeah, bruising, nosebleeds. Those were the main thing. Gum bleeding out of nowhere. It was always right after an exposure, and it just so happens I moved to New Jersey then, and I was living in a water damage apartment. So I know that. I know New Jersey.
I'm from Jersey too.
I'm sorry. My experience was
Jersey.
there's beautiful things in New Jersey. My experience, unfortunately, living there was a really bad timing because the illness came around and I happened to land in, the water damage space. Okay, so I know we have more questions, but we are going to wrap up the session. I mean, there's a bunch of other things I would love to talk about. Maybe in a future IG Live, we could try to do something if you're. Yeah, because there's just so much, and you're a wealth of knowledge, and I love the way you think about this. You have the scientific thinking, which is, you find patterns, you don't fully understand them, but you want to figure out what's going on, and you go through that, and then you start putting pieces together to create some plausible causal picture of what's going on. And I think that's like a very powerful tool if when you do it appropriately, and you're one of these people who's able to do that, and also at the same time help patients, in terms of practically or clinical practice. So I know there's a lot more that we can talk about, but I want to thank you again for joining.
Absolutely. Thank you.
Yeah, and hopefully, we'll do something then in the near future again.
Yeah, we have to get together. Maybe I'll come down to your
Oh,
neck of the
one
woods.
more question. So I know people are interested in working with you. How can patients? So first of all, do you work with patients remotely, and how can they set up to work with you for a session consultation?
Yeah, absolutely. So I work at the Amen Clinic in Reston, Virginia. But I see patients all over the country. I've got
Okay.
lots of medical licenses, and I see people all over.
Okay. So they would just need to go through the Amen Clinic
They
website.
would.
Okay.
Yeah, they would need to go through the Amen Clinic. If you go to the website, the Amen Clinic website, there's a phone number that you can call or an email that you can email to set up, to set up those appointments.
Okay. And they
And
can specifically request to work with you?
yeah,
Is
yeah.
that
And you don't
okay?
have to see a psychiatrist to work at the Amen Clinic, to come see me at the Amen Clinic. You can just see me. And I have a lot of patients who do that. They just come to see one person. That's totally fine.
Yeah. Okay. Great. Well, thank you, Jackie. Again, it's a pleasure. And
Yeah.
yeah.
Yeah. It's so good to
Okay.
see you, Kristen. Have a great
Th-
holiday, okay? Thank you,
Thank you.
everyone, for participating.
Yes. Thank you, Jackie, and thanks everyone for joining. And so happy holidays to
You
everyone.
too. Bye.
Bye.